to thank the organizing committee of the Turkish Association for Psychopharmacology for this invitation to speak on depression and the effect of antidepressants on sleep. First, I will try to give some good reasons why depression and sleep are strongly linked. And as you already know, insomnia is common in depression. It has been mentioned before. And it may be the presenting complaint of depression. And we know that from several epidemiological studies that have shown that up to 90% of depressed patients complain of poor sleep, and conversely that approximately 20% of subjects with insomnia screened in general population studies are found to be depressed. Moreover, the percentage of patients with major depression have more than one sleep complaints, either difficulty falling asleep, interrupted sleep, or early morning awakening. So that's a very, very common symptom of depression. Now, second, another reason is that sleep disturbance may predict treatment outcome in cases of depression. And there are many subjective reports of sleep disturbance and objectively assessed polysomnographic abnormalities that correlate, that have been correlated with an increased risk of new onset major depression, persistence of depressive symptomatology, recurrence of depression following successful treatment. Therefore, there is a prognostic value, let's say, in sleep disturbance symptoms in depression. This is to show you that even after successful cognitive behavioral treatment in depression, recurrence is more likely if there is abnormal sleep. The green line shows the much lower risk of relapse within the next several weeks following treatment, and the red line conversely shows that patients treated but with still abnormal sleep profile relapse much faster than the rest. Another reason is that, as you probably know, sleep manipulation, either the manipulation of the circadian or the homeostatic component of sleep, may alter mood. And probably you are familiar, or excuse me, you are familiar with the fact that sleep deprivation temporarily improves mood in depressed patients, but unfortunately there is, after a recovery sleep, the effect vanishes, and we have an increase, in this case, on the Hamilton Depression Score. Several manipulations of the sleep-wake cycle, either of the type of the total or partial sleep deprivation or the phase advance of sleep, have profound and rapid effects on depressed mood in a very high percentage of all diagnostic subgroups of affective disorders, and this therapeutic effect possibly is linked to an increase in the homeostatic sleep pressure. Unfortunately, this is a short-living effect, and many times we combine sleep deprivation with lithium or pindolol that has better results and may prevent relapse. Also, light therapy that acts as a synchronizer in the treatment of patients with seasonal affective disorders is an indication of the significance of sleep in the case of depression. And this effect of light therapy is also has been shown to be valid also in non-seasonal depression. Finally, there are laboratory data showing that sleep architecture is abnormal in depression. You all know that, well, at least those of you who are psychiatrists, that there was a lot of work done during 2 decades ago on REM sleep and the biological, let's say, significance of REM sleep latency, short sleep latency in depression, and slow wave sleep, and the quantity of slow wave sleep during the first cycle in the night. I don't know if you are familiar with the hypnograms, but this is a normal hypnogram, the hypnogram of a normal subject, showing the different stages progressing throughout the night. And as you can see, normally REM latency is around 70 minutes. That is the occurrence of the first REM period is around approximately 70 minutes after sleep onset, and normal subjects usually have a high sleep efficiency at the range of 95%. And this is the hypnogram of a depressed patient. You can notice how short. Oh, sorry. You can notice the arrow shows how much shorter is REM latency. Multiple awakenings, these vertical yellow lines show the number of awakenings during the night, and you can also see that this deepening of the lines show that there is more slow wave sleep in the second cycle of the first part of the night. All these are abnormalities that are very characteristic of depression. Unfortunately, they are not found uniquely in depression. This is not there is a low specificity of these findings. You can find such abnormalities in other neuropsychiatric conditions, but anyway, these are very common and typical of depression. So there is a difficulty initiating and maintaining sleep, and there is a decrease in general of slow wave sleep, of deep sleep, let's say, and a shortening of REM latency, and a slight increase in the percentage of REM sleep. Especially regarding slow wave sleep or deep sleep, delta sleep, this is the normal distribution of delta sleep in humans during the night, and you can see that most delta sleep is let's say concentrated in the first part of the night, and then there is an exponential decrease of delta sleep throughout the night. And here you can compare these two graphs. The top graph is the delta sleep of a normal individual, and the lower one that of a depressed individual. You can see, first of all, that there is an overall decrease of delta sleep in depression, and also a more uniform, let's say, distribution of delta sleep, which is represented in what is called the delta sleep ratio, most uniform distribution of delta sleep during the night. So Now, all these polysomnographic abnormalities led to several hypotheses regarding the pathophysiology of depression and sleep. And first of all, both monoaminergic and cholinergic neurotransmission are heavily involved in both conditions, and several hypotheses had been advanced, such as the hypothesis of an increased REM sleep pressure in depression, the hypothesis of a deficiency in the mechanism which is responsible for non-REM sleep, which is it's an indication of a deficiency of the process S, as we call in patients with depression. And finally, the hypothesis of imbalance between the monoaminergic and cholinergic systems in the central nervous system. Now, what happens with antidepressants? Antidepressants change sleep architecture. That has been documented a long time ago. First, investigators were mostly interested in their action on REM sleep, so we very well know that antidepressants change REM latency, most of them at least. So this is an example of what happens after the administration of an antidepressant in a depressed patient. In this example, after the administration of an SSRI, the top graph is before treatment, which is typical of an hypnogram of a depressed patient, and the bottom graph is after 3 nights of paroxetine administration, which is very close to what one would expect from a normal subject. So the mechanism responsible for this action, it's the increase probably of noradrenaline and serotonin, which is due to the administration of antidepressants, which inhibits the cholinergic neurons in the pons of the brain stem, probably via 5-HT1A receptors, which strongly suppresses REM sleep. So it has been proposed that it is central to the therapeutic effect of the majority of antidepressants, this strong and sustained suppression of REM sleep. And studies on SSRIs have shown that increases in serotonin levels could mediate the effect on REM sleep. However, there are changes in non-REM sleep and sleep maintenance that probably are mediated through the action of other neurotransmitter systems. And this is the case, let's say, with paroxetine, where probably it has been proposed that it's not the action on REM sleep that leads to this graph, which is that delta sleep is concentrated in the first part of the night and normalized, but it's mostly the action on slow wave sleep that is important, and not the action on REM sleep, which is suppressed in this case by phenelzine. Now, that's a general idea, to give you a general idea of the effects of antidepressants on sleep early in treatment, first days of treatment. Almost all of them reduce total REM sleep time. And something's wrong here. Arrows have vanished anyway. And there is an increase of REM latency. Regarding sleep efficiency, things are somewhat different. That is, at the beginning of treatment, most antidepressants, tricyclics, monoamine oxidase inhibitors, SSRIs and SNRIs, all of them have a kind of disruptive action on sleep efficiency early in treatment. This is not true in the case of nefazodone and mirtazapine, which unfortunately also here arrows have vanished. There should be upward-looking. There should be upward-looking arrows here, which are increased sleep efficiency very early in treatment. So the majority of antidepressants suppress REM sleep. There are some exceptions, however. Mineptine, tianeptine, nefazodone, trazodone, bupropion, and trimipramine do not have clear-cut REM suppressant effects. Most SSRIs, also and clomipramine, show evidence early in treatment of having some stimulating effects, thereby reducing total sleep time and sleep efficiency, and promote wakefulness. These effects, however, are short-lived, and there are few significant differences among drugs after a few weeks of treatment. Also, one has to remember that sleep continuity and total sleep time are improved with sedative medications, such as mianserin, mirtazapine, nefazodone, and trazodone. Now, what happens now during long-term treatment, and that's perhaps the most important part, because antidepressants usually take a few weeks to exert their therapeutic actions, and that's very important to know what's the long-term effect of antidepressants. Regarding REM onset latency, after long-term treatment of antidepressants, as you can see, there is a a good profile regarding REM onset latency, even after 3 months on SSRIs or tricyclics. REM onset latency is above the mean, so that could be of therapeutic value. This is also shown here with, in the case of fluvoxamine, you can see that even after 3 months, the REM latency measured in minutes is well above the mean average. But this is not true regarding REM sleep, the amount of REM sleep. There is a drop, a sharp drop at the beginning of treatment, but the total amount of REM sleep gradually returns to baseline after most antidepressant drugs. Unfortunately, and this is interesting, antidepressants, in this case tricyclics and SSRIs, do not have a much favorable profile regarding sleep continuity. They do not really restore sufficiently sleep continuity, at least after long-term administration. So you have to remember perhaps that the tricyclics on short-term administration promote sleep by increasing, not all of them, total sleep time and slow wave sleep. REM sleep is suppressed by all TCAs except trimipramine. Imipramine and decipramine are less likely to be linked with sedation, and have been associated with insomnia. Some of the tricyclics, because of their sedating properties, are often used as hypnotics in depressed patients who suffer from insomnia. The problem is that quite frequently TCAs may induce or worsen periodic lip movement disorder and REM sleep behavior disorder, and their administration can very frequently cause nightmares. Now, the monoaminoxidase inhibitors in general disrupt and disturb sleep much more than the tricyclics, and they may cause insomnia in a high percentage, approximately 60%, during their use. They may increase daytime sleepiness by decreasing total sleep time, and also you have perhaps to remember that they are very strong suppressors of REM sleep and may cause a REM rebound upon withdrawal. Moclobemide, which is a reversible MAO inhibitor, has a better profile and does not affect sleep notably, and all monoaminoxidase inhibitors may cause REM sleep behavior disorder. Now, regarding the SSRIs, as I already mentioned, they increase REM latency, and REM latency remains increased after several weeks of treatment. REM sleep is reduced, but there is a partial recovery after several weeks. They decrease total sleep time. That is, they are more energizing agents than other antidepressants, and therefore they are commonly associated with insomnia. In some cases, when high doses of SSRIs are given, sedation and daytime sleepiness may be reported. Fluvoxamine and paroxetine are regarded as the most sedating of all SSRIs, and conversely, citalopram has been reported to be the most sleep-disturbing SSRI. SSRIs can also exacerbate periodic leg movement, limb movement disorder, and cause nightmares, and especially fluoxetine has been associated with RBD. Now, what is interesting is that despite the above, patients' subjective sleep ratings while taking SSRIs are frequently positive. And the same is also true in terms of clinicians' ratings of sleep items on the Hamilton scale in clinical trials. And this has been shown in this study, where you can see that there is a discrepancy between what patients treated with fluvoxamine report as better sleep and the objective findings from polysomnography, where you can see that more EEG awakenings are reported from responders than non-responders. So perhaps I'll go over the rest faster because we're running out of time. Yeah. Trazodone and nefazodone are very sedative antidepressants, and therefore can be used for the management of severe insomnia and depression. Maprotilene, amoxapine, and tianeptine can cause sedation and can be used in cases of severe insomnia. Now, SNRIs and NRIs may cause insomnia in a small percentage of depressed patients, and especially venlafaxine has been associated with RBD. Mirtazapine enhances, is the sleep enhancer, let's say, but its action is due to its potent antagonism of H1 receptors, and this can cause immediate and non-specific sedative effects. That's one of the drugs we prefer in the case of severe insomnia. And last, the melatonergic antidepressants, agomelatine, which is MT1 and MT2 agonist and 5-HT2C antagonist, is a novel approach to the treatment of depression and sleep. It combines circadian synchronizing effects with selective norepinephrine and dopamine augmentation properties in the prefrontal cortex. And when it is given in the evening, it advances the circadian phase and directly increases sleepiness through thermoregulatory mechanisms. These may promote a rapid sleep onset without any after effect for the following day. It improves sleep quality and sleep continuity by increasing duration of slow wave sleep without modifying REM sleep, and probably is a promising approach for depressive patients with sleep problems. So I would like to conclude that sleep is a useful biological measure which shows changes in depression and can be used to explore the mechanism of action of antidepressants, and that antidepressants vary markedly in their effects on different elements of sleep, and this may have significant clinical consequences. Thank you.